Thank you, sir. We all refractive surgeons, most of us who are sitting here and many of us, we have been using posterior chamber phakic IOL for last so many years. And there have been many issues with these phakic IOLs, and most of them have been sorted out. But there's one query that still remains, and that is about the sizing, and many times we get these surprises in vaults. So we would just like to discuss whether the sizing is still a concern. So how does sizing affect an ICL? It affects the vault of the ICL. And what should be the normal vault? The normal vault should be something around between 250 to 750 microns. And with the current generation ICLs, when we have a central aqua port, we can go a little lower, like maybe up to 200 microns or maybe up to 1,000 microns also is manageable. So something between 200 to 1,000 is still acceptable. Lower than that is not acceptable because we all know that the vault even reduces with time. And higher than that will have its own problem in terms of causing glaucoma. Although with the central aqua port, the pupillary block is not there, but then it shallows the peripheral angle, and that can cause glaucoma. So there are ample reports of cataract formation due to low vault in individuals who have undergone ICLs. And there is one report also about the occurrence of uveitis because of low vault. And if the vault is too low, then what happens that there is increased contact of, increased area of uveal tissue is in contact with the ICL. And because of the pupillary movement and all these, there is more rubbing and pigment release, and that can cause uveitis. This is one example of a case wherein the vault was low, 180 microns, and then the patient came to us with uveitis. This was treated with steroid and it resolved, but then it is one possibility with a low vault. If the vault is too high, as I said, that the pupillary block is almost gone, but if you have a too high vault, then the peripheral angle becomes narrow, and there's a risk of synechia formation, because if there's any inflammation, the surface becomes a little sticky, then the risk of synechia formation and high IOP is very much there. So the question is that we have been working so much these lenses, why this vault surprise, why the sizing is still a challenge? The reason is this, that we calculate the size of the ICL based on the white to white, and then we add to it and get the final size. Now the lens is there in the sulcus, and it has been noticed that the size of the sulcus is 0.42 millimeter more than the white to white diameter. However, the relationship is very much variable in different axes, and that is the reason why many times we do get surprises. So what are the options? What we can do if the vault is too low? If it's a very low vault, less than 200 microns, you should explant and replace with one size bigger. There's no doubt about it, because the vault will further decrease in due course. If the vault is high, more than 1,000 microns, 1,000 to 1,200, if it's too high, more than 1,200, then obviously again you have to explant and put an ICL of a one size smaller. But if it's something borderline between 1,000 to 1,200, then you may wait for some time, for maybe 1 to 2 months time, and see how it behaves. And there have been reports that there is no fibrosis. It's a very biocompatible material. So if you want to manipulate the ICL even after a year or so, there is no issue at all. Because with IOLs, we get to see the fibrosis around it. But with these Collamer lenses, I had a case wherein there was a lady who was slapped by her husband, and the ICL moved on to the anterior chamber. So that was one example wherein we concluded that it is really a biocompatible material, wherein surrounding the foot plates there is hardly any fibrosis and inflammation. So you can obviously modify it. So maybe you can wait for a couple of months and see whether the vault is reducing or not. If the vault is not reducing, and if it's a spherical ICL, in that case you can rotate the ICL and bring it vertical, because vertical sulcus to sulcus diameter is more than horizontal. However, if it's toric, then you can't rotate and you have to replace with one size smaller. This is one example wherein we can rotate the ICL, bring it from horizontal to vertical, and see in the post-op period what is the vault. However, the intraoperative OCT microscopes, they help us to know on the table itself whether the vault is, has reduced or not. Mind you, the accuracy of the vault will not be very good when you are doing intraoperatively because there is viscoelastic in anterior chamber. So the vault will be slightly low, and when you have removed it, there's risk of shallowing of the chamber. So again, the vault can be a little high, but it will give you a rough idea that if it was 1200 earlier and it has reduced to 600, even with the viscoelastic, it will not increase to more than 800. So this is what is useful if we have intra-op OCT. So you rotate the ICL, bring it vertical so that it is now into a larger dimension of the sulcus so that the vault reduces. And this is how we do it. What is most important in this is that when we are rotating the ICL, we should have a well-dilated pupil and we should inject viscoelastic at the edge of the ICL so that some viscoelastic goes underneath the ICL as well, like when we are rotating it, there's a cushion of viscoelastic behind the ICL. This is the one example of a case wherein this was a post-operative vault, and after rotation on the table we could see that the vault has reduced significantly. We did a study, and we have 3 minutes. We did a study wherein we wanted to know the repeatability in white-to-white measurements, because that is also one issue wherein we can have problems. And we compared with sulcus diameter, and what we did was we measured white-to-white diameter with OpScan 2, iTrace, LensStar, IOLMaster, and digital calipers. And we measured the sulcus to sulcus diameter with UBM. Now, there are a couple of studies that show that UBM gives a better result. However, there is variability of measurement of UBM because of 2 reasons. One is that the section is not proper when you have captured, and the measurement is not exactly from the end point to the end point. So you can have issue. The further thing is that the recess can be variable, and when you are putting the cursor, which is done manually, you can have variability in measurements, and it is there in literature, and we also found out. So that's why it is very important that the largest posterior lens capsule and the largest pupil size in all your scans indicates that the position is central. So there's another method which we got was that if the image is symmetrically aligned with iris and the cornea, anterior and posterior lens capsule are balanced over a theoretical vertical line, then it is a good scan of UBM. And then we saw the repeatability of findings, and we found out that as you can see here in UBM, the repeatability was not, it was okay but not very good. The best was seen with IOLMaster. The least coefficient of repeatability gives the idea that this has the best repeatability. We implanted the ICL based on the OpScan finding as we used to do at that time. These days we are only relying on digital calipers. Then this was the difference between the different methods of white to white. And we did the sulcus diameter and we rounded off at the nearest point. Like if the sulcus diameter with UBM is 10.7, we'll make it 11. If it's 10.3, we'll make it 10.5. So this is how we rounded off. And then we just took the ICL size, which was just ahead of that. We found out that 80% of individuals had a good vault, absolutely acceptable vault with OpScan. Additionally, 7% had better measurements with when we compared it with UBM. And these are some of the examples wherein the vault were abnormal with OpScan, and it was better with UBM measurement. And we found out that the repeatability was best with IOLMaster. And since we not everyone will have all the machines, so if we have IOLMaster and we are measuring white to white with that, then a correction factor of 0.364 can be used with the digital calipers or the OpScan 2, and best with the digital calipers, and then we can have the accurate measurement. the study concluded that the sulcus diameter is not the only thing that can give you the best results. The white to white is not the only thing that can give you best results. So the nomogram should include both white to white and sulcus diameter in order to have an additive effect so that we can get the most accurate size of implantable Coulomber lens. Thank you very much for your patient listening.